we will learn about the causes of nonlinearity. In the previous session, we learned about what is nonlinear pharmacokinetics, how that nonlinear pharmacokinetics is detected. Now, this session will emphasize which are the different causes that contributes for the nonlinear pharmacokinetics. The nonlinear pharmacokinetics occurs when the drug absorption, distribution, metabolism, and excretion processes become saturated and dose dependent, which leads to disproportionate changes in the plasma drug concentration with the dose adjustments. The key causes for the nonlinearity are absorption, distribution, metabolism, and excretion related. Generally, the elimination causes are majorly than the absorption and distribution. Now, which are the causes under drug absorption? So, when absorption is solubility or the resolution rate limited, especially the drugs which are poorly water soluble but having the good lipophilicity, at higher doses, such drugs become saturated in GIT. And the absorption of such drugs become a problem. Especially, you know about this greaseprevir, antifungal antibiotics, which causes this one. So here, the solubility is a cause. The second point, when the absorption is limited by the carrier mediated. So we understood about the active transport of the medications. When absorption of ibuprofen, ascorbic acids, cyanocobalamin, and many antibiotics, they are transported, they are absorbed through active transport, especially carrier-mediated transport. Saturation of such transport system at higher doses results into the nonlinearity. When pre-systemic gut wall, the hepatic metabolism becomes saturated, especially there are certain drugs that at the higher doses, the first pass metabolism compromised because of saturation of such enzymes. That leads to increasing bioavailability. If we see out of these 3 points, the point 1 and 2, where the PK parameters decreases, and 1 in point 3, as the pre-systemic circulation retards, so more drug will be available into the plasma, thus the bioavailability increases. There are certain other causes of nonlinearity related to the absorptions are changes in gastric emptying period, the blood flow in GI, and other physiological factors. Moving to the next, which are the causative agents for the drug distribution? So the nonlinearity, especially in drug distribution, occurs because of binding of drugs to the plasma proteins as well as to the tissues. Now, when drug binds to the plasma proteins, what happens? There are certain finite number of binding sites for the plasma proteins. And the saturation of such proteins, especially albumin, alpha-1 acylglycoprotein, increases free drug concentration into the plasma. So after this saturation, the concentration of drug in the plasma increase, that is fraction unbound increase. So examples like phenylbutazone, naproxenes, if the doses increases, they exhibit this kind of saturations, and thus the concentration in the plasma increases. In the other way, in the distribution, the tissue binding becomes saturated, especially thiopentol and fentanyl. In the high doses, the saturated tissue storage sites and the altering the volume of distribution. With large single bolus doses and the multiple dosing, especially saturation of the tissue storage sites can occur. So both plasma proteins as well as tissue binding sites become saturated at the higher doses of drugs. Those are the most important contributors from distribution point of view. Moving to the another causative point, that is drug metabolism. The nonlinear kinetics, most of the clinical importance is the capacity limited metabolism. So this is the most important causative agents. It's a major source of large inter-subject variability in the pharmacological response. As the metabolism is capacity limited, metabolism fluctuates because of saturation, thus the pharmacological effects fluctuates. We will understand the 2 important points under the metabolism. One, when the metabolism is this capacity limited, especially that metabolism happens through the enzymes and the cofactors. And when such enzyme becomes saturated, that capacity limited metabolism happens through Michaelis-Menten kinetics. So there are certain drugs like phenytoin alcohol theophylline exhibits capacity limited metabolism. In the second one, enzyme induction. The enzyme induction alters the drug metabolism over the time, leading the time dependent changes in the clearance as well as plasma drug concentration. So here there is also increased metabolism capacity over the time. Taking the examples of carbamazepine, which induces its own metabolism, that is, it undergoes auto-induction. And after that, the other drugs, by activating the nuclear receptors, especially PXR, that is pregnant X receptor, which boosts the enzyme production. Time-dependent clearance that happens in the enzyme inductions too, especially with the repeated dosing, enzyme levels increases, enhancing the metabolic clearance, and this shifts kinetics towards from zero order or the mixed order behavior. So there is a switch from first order to the mixed order because of time dependence clearance. At the small level, at the small function, at the initial time, enzymes are not that much activated. But as the time process, the enzymes activated, and that leads to increase in metabolism rate. So saturation of enzymes results in decrease in hepatic clearance and therefore increased steady state plasma concentration. The reverse is also true if the enzyme induction happens. There are certain, apart from enzyme induction, inhibition, and capacity limited metabolism, other causative agents for the metabolisms include saturation of the binding sites, inhibitory effects of the metabolites and the enzyme, pathologic situations, especially hepatotoxicity, changes in the hepatic blood flow, and many others. Moving to the next, the drug excretion is also one of the most important contributor for variability in linearity. So it's another source of non-linearity. So we know renal as well as sometimes biliary elimination pathways of drugs become saturated at higher doses. So this leads to dose-dependent changes in elimination and the pharmacokinetic parameters alters. Focusing on the renal excretion, we know about how renal excretion happens. So many drugs that involves in the excretion through renal or urine involves both passive blood filtration as well as active transport. Active transport especially active tubular secretion as well as tubular reabsorption. The active tubular secretion and reabsorption are mediated by the carriers, the proteins that transport, which have the limited numbers. So they have finite capacity. At low concentration, this process follows first order kinetics. But when the concentration of drug increases, at higher concentrations, these carrier systems become saturated. The process kinetics to the zero order kinetics, and that leads to non-linearity. The two important active processes in the renal excretion which are saturated is active tubular secretion. The best known example is penicillin. After saturation of the carrier systems, a decrease in renal clearance occurs because no drugs is available for the clearing. Active tubular reabsorption is especially water-soluble vitamins and the glucose. After saturation of the carrier system, there is an increase in clearance occurs. So in active tubular secretion, clearance decreases, and active tubular reabsorption clear increases. So these are the different variabilities are there. There are certain other sources of non-linearity in the renal excretions, which includes the forced diuresis, changes in the urinary pH, some disease conditions like kidney failure, nephrotoxicity, some saturation of binding sites. Those are the other contributors for non-linearity in urinary excretion. Biliary excretion, right, which we specifically call as biliary secretion, which is also the active process and is also subject to the saturation. The examples of drugs which contributes for this non-linearity in biliary secretions like tetracycline and indomethacins. So these are the different sources of non-linearity. So in a nutshell, that non-linear increase the plasma concentrations There is a dose-dependent clearance, the half-life altered, and there's risk of accumulation of drugs, and thus the toxicity may observe. So let's conclude what we learned in this session. We learned different sources of variability of nonlinear pharmacokinetics. So from absorption, especially the saturation of transporters, especially active transports, become saturated. In distribution, protein and tissue binding sites become saturated. In metabolism, enzymes become saturated, or sometimes autoinduction may contribute for the non-linearity. In excretion, the tubular secretion, tubular reabsorption saturated, and that leads to non-linearity. So this is it in this session. Thank you very much. Have a happy learning.